When I was working in the emergency department as a junior doctor fresh out of medical school, an elderly woman had come in unwell with fever, confusion and low blood pressure. I immediately suspected a severe bacterial infection, perhaps involving the patient's bloodstream. I dutifully prioritised her assessment and collected blood samples to send to the laboratory in order to identify the culprit pathogen and diagnose the infection. As it currently stands in our hospitals, to diagnose bloodstream infection, blood is collected into bottles containing nutrients that promote bacterial growth. These bottles are then stored in the laboratory until bacterial growth is detected. It is only after significant bacterial growth that the species of bacteria can be identified. It takes even longer to determine which antibiotics may be best used for treatment. Altogether, this process can take up to 3 days to complete, sometimes longer. During this time, clinicians are essentially treating their patients blindfolded. For severe and life-threatening infections, this process is simply too long. My research focuses on delivering this key information to treating clinicians much earlier during illness. That is, to not only identify the species of bacteria in the patient's blood, but to determine which antibiotic would best kill it. We can now use DNA sequencing technology on human blood samples to identify bacterial DNA and antibiotic resistance genes. It has become quick, cheap, and easy to use. Preliminary studies indicate that we can obtain this key information in less than 6 hours. This will enable doctors to rapidly adjust their antibiotics to better target the offending pathogen and improve patient recovery, reducing the risk of death from sepsis. This approach will be assessed in a large-scale cluster randomised controlled trial, where different hospitals will incorporate this novel testing strategy at different time points during the trial. Patient outcomes, such as the time taken to cure infection, and health economic outcomes such as cost, will be compared between the new and old platforms. Now, back to my patient. After collecting blood, I immediately commenced antibiotics targeting the most likely bacteria causing her illness. 24 hours later, I had learned that her condition had worsened and that she would likely succumb to a severe bacterial infection. And despite the best available medical care, she passed away. It would only be after her death that we would learn that the bacteria identified in her bloodstream would be resistant to all but a few available antibiotics. We must do better.